Okay, so now we'll look at external balance, which basically means the way kidney handles, the nephron handles potassium. This is a busy slide. Again, I would advise you to keep a pencil or a pen and a piece of paper handy. You may want to take down certain points so that the whole topic gets prepared in one go. Okay, so there are three sections of this slide. One is the overall potassium handling by the nephron, some important bits here. Okay, the second part of this diagram is where we'll go through this section of the DCT. So a blown up picture of the alpha intercalated cell, which I mentioned in the previous slides, previous lectures. Principal cell, which I have explained in detail when discussing sodium homeostasis. And then we'll talk about the overarching regulation of potassium excretion, which has all sorts of factors in it. So saddle up. We start from the left. We look at the nephron as a whole, and you see the pattern here where we discuss overall chunks of potassium being handled, very similar to what we saw in sodium handling by the nephron. But here the percentages are a bit different. This is the same, 67% potassium is reabsorbed at the PCT. However, unlike 25% that gets reabsorbed, sodium that gets reabsorbed at the thick ascending limb of loop of Henle, 20% of potassium gets taken up from here. Now, this is where again, sodium got interesting, because this is where aldosterone does all sorts of things. When sodium reabsorption, where we were talking about, here we see that when we talk about potassium, the diet becomes important, and then you have variable secretion. So reabsorption will take place if the diet is deficient in potassium. Secretion means that you are in your system there is more potassium than required. So it's going above 5 milliequivalents per liter statistic. So you will have variable secretion, okay? And this secretion will depend on these five factors, which is, one is again diet, the other is aldosterone, third is acid base, then flow rate, and then luminal anions. Here I will just make a footnote. Look at the regulation chart here. You have physiological factors, then you have pathophysiological factors, okay? So under physiological factors, we say that these are the ones that keep a balance of potassium intake and outtake in routine. So this goes on in routine. You have the plasma potassium, which dictates whether there will be uptake, reabsorption of potassium, or secretion of potassium. You have aldosterone, which the details of which we'll be discussing soon. And then you have ADH, which also has something to say about potassium. It affects potassium levels in the ECF. Okay, you need to refer to ADH, the info diagram that I sent out. Then you have pathophysiological factors, which basically displace potassium balance. These are the ones that there are the issues which are not specific to potassium itself. There are other issues related to other stuff. So flow rate, as an example, flow rate depends on sodium, water, and whatnot. It doesn't directly link with potassium, but it has consequences for potassium. Okay, so these are factors which are unrelated with potassium homeostasis, but end up affecting potassium balance. Acid base, like we just discussed, also will come into play here as well, as it was discussed in the internal balance of potassium. Acid base, again, is not primarily a fault of potassium. However, it ends up disrupting a lot of potassium here and there. Okay, so this diagram can be read as physiological and pathophysiological factors as well. Okay, so having looked at the overall picture of what happens in potassium handling, and you can also see that excretion, if the person is deficient in potassium, he will only secrete about 1% of the total tubular load of potassium. However, if there is more potassium in the system, this can go up to 110% of secretion of potassium. And look at this value. and correlated with the plasma value of potassium of 3.5 and to 5 milliequals per liter. And you will see how kidney, serious a function kidney plays in the excretion of potassium, and how this is the main factor which holds the tight fort of plasma potassium. Okay. Now, then let's look at the tech. What is the technology which is behind all of this tight regulation of potassium? We see that you have the alpha intercalated cell. This is again alpha intercalated cell, and principal cells are two recurring cells, clusters, which happen to be along the DCT and a bit in the early collecting duct, if memory serves me right, but mainly the DCT. Okay, and if I may label this cell as a potassium reabsorber. So you can see potassium coming here as part of the same hydrogen potassium antiport mechanism that we discussed in the internal balance. It moves potassium from the lumen inside the cell, and then potassium is transported across the basolateral border and into the blood. Okay, so this is a clear-cut reabsorber of potassium. However, the principal cell, as you can clearly see, is a potassium secretor. It's a potassium secretor. So reabsorption of potassium and secretion of potassium. You will say, hey, what's going on here? These cells seem to be contradicting each other. Well, it's not, the word is not contradiction. The word is balance. So check this out. If you have deficient potassium diet, if you are on a low potassium diet, then you will have potassium reabsorbers, the alpha intercalated cell, doing most of the business. Okay, because that's what you need. Your diet is low in potassium. You cannot afford to excrete any more potassium than you have to excrete. Okay, so you will reabsorb most of the potassium that comes the way of the DCT. However, and then this secretion will be, it will be snubbed in this scenario. However, if you are high on a high potassium diet, then what would you know? What would you be doing? You will decrease the working of this cell and increase the secretion by the principal cell to get rid of the extra potassium. So you now understand what is the overall function of an alpha intercalated cell and the overall function of the principal cell. One is reabsorber, one is secretor. Now, let's come to the bits here. Let's come to these things now. First, we'll look at the diet. We have mentioned the diet, but let's see if we have missed on something. Before I go into this whole thing of what the DCT does with potassium, whether it's alpha intercalated cell or principal cell, I want to just clarify one basic golden criteria in potassium handling of the DCT. Always remember that it's all about the potassium gradient within the cell. And when we're talking about basically the principal cell, which is the secretor, because look, we're talking about secretion now, basically. So we are talking about primarily the secretor, the principal cell, okay, which comes into play when you have more than what you can handle in terms of potassium. So it's all about the gradient. What is the gradient? The gradient is established by the ATPase at the basolateral border, which keeps on pumping potassium inside and sodium outside. So it keeps on concentrating potassium here so that it can be promoted. The secretion can be promoted. Now, whoever and whatever compound or whatever phenomena going on in blood or wherever will stimulate this ATPase, will add to the concentration of potassium inside the cell. And this gradient will be enhanced. Remember, it's all about the gradient. When this gradient will be enhanced, naturally, the secretion will be promoted. So with that in mind, let's look at these factors. So one is diet. Basically, diet, again, it basically enhances the gradient across the DCT cells. And remember insulin that we talked about? So insulin also works on these cells. It enhances the ATPase. It pushes in more potassium, and hence it gets secreted from the luminal border. Okay. So this action, it's an interesting point. An add-on would be the effect of insulin, which we discussed in the internal balance. Number two is aldosterone. Now, remember, aldosterone is a busy hormone. Aldosterone gets secreted by angiotensin 2. We know when angiotensin 2 is made, the whole renin pathway. So keeping that in mind, let's just pick up proceedings from aldosterone onwards. Aldosterone, basically, what does it do? Aldosterone reabsorbs sodium, and along with it, it reabsorbs water. This is what we have done up till now, okay? Because we've been discussing volumes and osmolarity and this, that, the other. But we've studied that. Now we've moved on. Now you see that this sodium uptake by this principal cell, it's a positive charge, right? Sodium is a positive charge. So is potassium. Now imagine this. If you pull in by a hormone called aldosterone, you're pulling in more sodium, okay? Which wouldn't have been the case if aldosterone wasn't there. But now that aldosterone is there, aldosterone will, if you have been doing your reading, will induce the formation of and increase the insertion of ENaC channels, epithelial sodium channels, ENaC, E-N-A for sodium, C for channel, ENaC channels along the luminal border of the principal cell, thereby increasing sodium reabsorption by this cell. Sodium gets more over here, okay? Now this sodium will repel the potassium. When it repels the potassium, that will aid to, in addition to the gradient you have already established for potassium, this sodium pushing in extra will electrically repel the potassium and aid its exit along with the gradient which we already talked about. So incoming sodium is actually linked with outgoing potassium. Said it another way, sodium gets reabsorbed by aldosterone, and aldosterone also causes potassium secretion. This is new knowledge. You might want to log that away. Sodium reabsorption, potassium secretion done by aldosterone. Now, you can have all sorts of scenarios which we will discuss, and maybe some will come in your assessment based on this effect of aldosterone. Now, aldosterone, besides inserting ENaC channels and making available these channels for sodium entry, also tends to stimulate ATPase. So it maximizes the effect of potassium secretion as well as sodium exit along the basolateral border. So number one is ENaC channel insertion. Number two is stimulation of ATPase. It also, by the way, a third lesser mentioned effect of aldosterone is it also increases the number of potassium channels along the luminal border. So not just ENaC sodium channels, stimulation of ATPase, but also increased in the number of potassium channels through which potassium can be secreted. Okay. So we have established the sodium-potassium linkage as far as principal cell is concerned and the effect of aldosterone on this linkage. Okay. There are two more interesting points here which go a long way in increasing the depth of your knowledge about not just this cell, but also potassium homeostasis and how it's linked with sodium homeostasis. So these two things are, number one, sodium diet. So effect of high sodium diet and low sodium diet has an effect on potassium secretion. And number two is diuretics. We'll do it in this order. So once again, we are just commenting on the sodium-potassium relationship as far as principal cell is concerned. And in this, we'll first mention the sodium diet. If you increase the sodium diet, there's more sodium which comes in the DCT here, and hence the delivery, the reabsorption of sodium is enhanced, which basically tends to push more potassium out. So let me just give you the context. If sodium is normal, potassium is normal, everybody's happy, nothing doing. No potassium disturbance is seen. However, if you start increasing intake of sodium exclusively, what will happen? What will happen is this extra sodium will obviously bypass the PCT. This whole statistic remains true. However, you have just increased the tubular load of sodium, right? So it goes here and then it comes here. When it comes here in the principal cell, this is what happens. You have more sodium coming in, hence you have more potassium going out. What happens to the body? What happens to ECF? If your answer is hypokalemia, you are right, sir. You are right. So a high sodium load in the DCT leads to higher uptake of sodium, which leads to higher potassium secretion because they are linked. I keep repeating this. They are linked. Sodium reabsorption and potassium secretion, they are linked. You increase the reabsorptive load here, you increase the potassium secretion. So what will be left here is less potassium. Hypokalemia. Same goes with now number 2, we mentioned the effect of diuretics. So there are 2 main diuretics. I'll be doing a separate video on diuretics, but an important point here needs to be mentioned. The diuretics, basically the thiazide and the loop diuretics, basically they work, the loop diuretics work on the loop of Henle, mainly the thick ascending limb of loop of Henle. And you remember what there is, the main important symporter is sodium, potassium 2-chloride symporter. We did that in concentration of urine, if you remember. So furosemide is a loop diuretic. It blocks this symporter and increases the amount of these solutes in the lumen. Okay. We have thiazide diuretic, which affects the sodium transporter in the proximal DCT, where there is no principal cell. Principal cell is in the later half of the DCT. In the proximal DCT, you have simple cells reabsorbing sodium. Thiazide diuretic blocks that, and loop diuretic blocks the symporter of the thick ascending limb of loop of Henle. Basically, both effects will lead to more sodium in the lumen. Yes, you see a pattern now. It's exactly the same that we talked about the high sodium diet, which means that when you're using these diuretics, you will increase the delivery of sodium in this lumen next to the principal cell, which again will enhance the sodium uptake and lead to more potassium being secreted. Now, the clinical addition here, the clinical point, additional point here is, if you're using a thiazide or loop diuretic, your patient will end up losing potassium. So you need to be very aware that if you have to use thiazide and loop diuretics in your hypertensive patients or your cardiac failure patients, why would you want to use the diuretic? Very quickly, to lessen the fluid in the cell, to get rid of extra fluid from this guy, so that the cardiovascular system, which is under load of extra fluid, gets relief. Hence the heart preload goes down, the heart also gets some relief. So diuretics are a mainstay therapy of hypertension and cardiac issues. That's why we are talking so much about diuretics. So these thiazide and loop diuretics do not make a point of conserving your potassium. This is like a huge issue. One is your cardiac patient, the patient is cardiac. 2 is the choice of drug that you've used is making potassium disappear from the system, hence making this guy hypokalemic. Hence you need to think about replenishing this person's potassium when you put him on these particular class of diuretics. And before I zoom out of this particular point, let me just say very briefly that there are potassium sparing diuretics which spare potassium. Okay, so more in the video on diuretics. That's that. Then we come on to we'll come on to acid base at the last. We'll just sort out flow rate. So flow rate is basically increased velocity of fluid through this system. So imagine that there is a normal flow rate through which the fluid flows through the nephron, and then there is an enhanced or increased flow rate due to whatever ECF changes, higher volume or high sodium presence in the CVS will cause more enhanced GFR, increased tubular load of fluid, and then increased velocity eventually of this fluid passing through the DCT. Now, if you have an increased rate, now imagine this cell right here, okay, with its inherent basic gradient for potassium, ready, secreting it already, and it's happy right now with a normal flow rate. Now you enhance the flow rate, you increase the flow rate. What are you doing? You are displacing fluid from here more quickly than the cell would like. So the gradient, imagine the gradient, would it across this luminal border, would it be enhanced or would it decrease? You have increased fluid velocity. So fluid is being cleared of this area, i.e. in front of this audience of potassium waiting to be secreted. It's getting cleared off quickly, more quickly than it usually does. It will enhance potassium secretion, because whatever potassium secretion that occurs, for example, now potassium is being held up here at normal velocity. At higher velocity, it will be cleared very quickly. So there needs to be more potassium, and then more potassium, and then more potassium. So flow rate enhances, increased flow rate enhances potassium secretion by aiding this gradient, i.e. clearing the potassium off from the lumen quickly, which then forces the gradient to enhance itself and release more potassium. This is how flow rate affects potassium. And finally, you have the acid-base balance. And acid-base balance, apply the same understanding that we had in here in the internal acid-base balance, that if you push hydrogen in, you'll have potassium out. This thing just put here at the basolateral border. Okay, just imagine this now. You have a hydrogen, a hydrogen potassium, a symporter situation. I beg your pardon. Let's look at this, the apical, the luminal border. Okay, you have the symporter right here. I did not notice it before. Okay, now when you have acidosis, you have acidosis in the blood, right? The ECF is represented by the blood and the interstitium of the cell. This side is the urine side. This side is the blood side. So when we say that the body has gone into, say, acidosis, we're basically saying that this blood and its next door neighbor, the interstitium of this cell, have become acidotic, i.e. they are more in hydrogen. So what happens? More hydrogen will be secreted inside the cell. Yes, more hydrogen here. It gets secreted into the, or put inside the cell. It gets secreted out because it needs to. It's acidosis. But then what happens to potassium? Potassium then gets reabsorbed, doesn't it? Because for electroneutrality reasons already explained. So this will result in, as I mentioned before, hyperkalemia. So hydrogen will move this way, potassium will move this way, and it will cause hyperkalemia, retention of extra potassium, where the original problem was with acid. It wasn't potassium's fault. The original issue was with increased hydrogen, but potassium had to come in because of the electroneutrality clause, and that's that. And you can work out what happens in alkalosis. It's the opposite. Okay. Now this is a